This is Lecture 09, Asthma, COPD, Anaphylaxis, and Angioedema. These conditions share an airway and breathing emphasis but require distinct strategies. The ED job is to recognize the dangerous phenotype, deliver category-specific therapy, and protect the airway when it is threatened. The objectives are these. First, recognize severe asthma and COPD exacerbations at the bedside. Second, deliver dose-specific bronchodilators, steroids, magnesium, and non-invasive ventilation. Third, recognize anaphylaxis and treat with intramuscular epinephrine first. Fourth, distinguish histamine-mediated from bradykinin-mediated angioedema and treat accordingly. Fifth, manage the angioedema airway with structured planning. And sixth, avoid the classic board traps. The ED mindset is that airway and breathing emergencies do not wait. Recognize the silent chest, the failing patient on non-invasive ventilation, and the angioedema airway before they decompensate. The right diagnosis with the wrong sequence kills. Epinephrine is for anaphylaxis. Permissive hypercapnia is the asthma vent strategy. Bradykinin angioedema does not respond to antihistamines. Plan the airway before it closes. Severe asthma is recognized at the bedside. Buzzwords for the boards: tripod position, accessory muscle use, and the silent chest, which signals impending respiratory failure, not improvement. Peak expiratory flow under 50% of predicted is severe. Capnography is a board favorite. End-tidal carbon dioxide starts low from tachypnea, then rises as the patient fatigues. A normal or rising end-tidal in a struggling asthmatic is a pre-arrest finding. Treat immediately with oxygen, continuous albuterol, ipratropium, systemic corticosteroids, and magnesium. Severe cases may need intravenous bronchodilators, ketamine, Heliox, and prepared ventilatory support. Asthma medication anchors are dose-specific. Albuterol nebulizer is 2.5 to 5 milligrams every 20 minutes, or continuous nebulization for severe cases. Ipratropium nebulizer is 0.5 milligrams every 20 minutes for 3 doses, then as needed. Systemic steroids: prednisone 50 to 60 milligrams orally, or methylprednisolone 60 to 125 milligrams intravenously. Magnesium sulfate 2 grams intravenously over 20 minutes for severe asthma. Ketamine 0.1 to 0.5 milligrams per kilogram intravenously, then infusion for refractory bronchospasm. Epinephrine intramuscular 0.3 to 0.5 milligrams may be considered for severe asthma when standard therapy fails. The board principle is that steroids do not work instantly, but early steroids prevent relapse. Refractory severe asthma requires layered interventions. Magnesium sulfate 2 grams intravenously over 20 minutes is the next step when standard nebulizers and steroids fail. Ketamine offers bronchodilation and sedation and is the agent of choice for refractory bronchospasm. Heliox, a mixture of helium and oxygen, reduces airflow resistance and is most useful in upper airway obstruction and may help bronchospasm. Intravenous beta agonists like terbutaline may be considered. Non-invasive ventilation, BiPAP, can buy time in selected patients and should be tried before the tube whenever possible. Intubation is high risk because the asthma physiology does not tolerate the apneic period or the ventilator. If intubation is required, choose ketamine for induction, use a large endotracheal tube, set a low rate with prolonged expiration, accept permissive hypercapnia, and be vigilant for breath stacking. Asthma intubation is dangerous. Patients are at risk for peri-intubation hypoxia, hypotension from positive pressure and auto-PEEP, and arrest. Optimize before the tube. Pre-oxygenate aggressively with bag mask plus PEEP or non-invasive ventilation if tolerated. Use ketamine 1 to 2 milligrams per kilogram for induction. Supports blood pressure, bronchodilates. Use rocuronium 1.2 milligrams per kilogram for paralysis. Use a large endotracheal tube, 8 or larger, for easier suctioning and lower resistance. Set the ventilator with a low rate, 10 breaths per minute. High inspiratory flow, 80 to 100 liters per minute. A prolonged inspiratory to expiratory ratio of 1 to 4 or 1 to 5 to allow exhalation. Tidal volume 6 to 8 milliliters per kilogram of predicted body weight, and accept permissive hypercapnia with pH down to 7.2. The board concept is to avoid auto-PEEP, also called breath stacking. The classic distractor is a normal respiratory rate setting. In asthma, a normal rate causes air trapping and circulatory collapse. If the patient deteriorates, disconnect the ventilator for 30 to 60 seconds to allow exhalation. COPD exacerbation is increased dyspnea, cough, or sputum production beyond baseline variation. The classic phenotypes are pink puffers, the emphysema patient who is thin and barrel-chested with pursed lip breathing versus blue bloaters, the chronic bronchitis patient who is cyanotic, edematous, and a CO2 retainer. The most common trigger for an exacerbation is viral upper respiratory infection, followed by bacterial superinfection with H. influenzae, S. pneumoniae, and Moraxella catarrhalis. Other causes include heart failure, pulmonary embolism, and noncompliance. Management includes bronchodilators, albuterol and ipratropium, systemic steroids, prednisone 40 mg orally for 5 days, or equivalent intravenous, antibiotics when indicated by the Anthonyson criteria, which are increased dyspnea, increased sputum volume, and increased sputum purulence. Treat when 2 of 3 are present, especially when purulence is one of them, or any patient requiring mechanical ventilation and oxygen targeting 88 to 92%. Non-invasive ventilation for hypercapnic respiratory failure or severe distress reduces mortality and intubation rates. COPD oxygen targeting is a board favorite. The target saturation is 88 to 92% in patients at risk for hypercapnic respiratory failure because chronic CO2 retainers depend on a blunted hypoxic drive. Excessive oxygen can worsen hypercapnia through 3 mechanisms: loss of hypoxic vasoconstriction, increasing dead space ventilation, the Haldane effect, oxygenated hemoglobin holds less carbon dioxide, and reduced respiratory drive in chronic CO2 retainers. The board concept is to titrate oxygen to the target, not to maximize it. Do not, however, withhold oxygen from a hypoxic patient. Treat hypoxia, then titrate. Non-invasive ventilation is most powerful in COPD exacerbation and cardiogenic pulmonary edema. It is helpful in selected asthma and immunocompromised patients. Contraindications include altered mental status with inability to protect the airway, vomiting, hemodynamic instability requiring intubation, facial trauma, copious secretions, and severe agitation. The board trap is leaving a failing patient on non-invasive ventilation too long. Signs of failure include worsening respiratory rate, decreasing oxygen saturation, rising carbon dioxide, agitation or somnolence, and persistent acidosis. Plan a time-limited trial with explicit criteria for intubation. Anaphylaxis is a clinical diagnosis. Criteria include acute onset with skin or mucosal involvement, plus respiratory compromise or hypotension, or 2 or more organ systems involved after exposure to a likely allergen, or hypotension after a known allergen exposure. Skin findings may be absent in up to 20% of cases. Common triggers include foods, peanuts, tree nuts, shellfish, milk, eggs, medications, antibiotics, NSAIDs, contrast, stinging insects, and latex. The most common trigger by age is food in children, drugs in adults, and insect stings at any age. The board concept is that anaphylaxis can present without hives or itching, and respiratory or cardiovascular compromise alone after exposure should trigger treatment. Anaphylaxis is an epinephrine disease. Intramuscular epinephrine is first line. Dose 0.3 to 0.5 milligrams in adults, 0.15 milligrams for children under 30 kilograms of the 1 milligram per milliliter solution, given intramuscularly in the lateral thigh, the vastus lateralis muscle. The classic distractor is subcutaneous epinephrine, which is slower absorbed and wrong. Repeat every 5 to 15 minutes as needed. For refractory hypotension, start an intravenous epinephrine infusion at 0.1 to 1 microgram per kilogram per minute. Titrated. Skin findings are not required to give epinephrine. Antihistamines and steroids are adjuncts, not rescue therapy. Delay in epinephrine is the strongest predictor of biphasic reactions and death. Adjuncts to epinephrine include H1 and H2 blockers, diphenhydramine 25 to 50 milligrams intravenous, plus an H2 blocker like Pepsid 20 milligrams intravenous, corticosteroids, methylprednisolone 125 milligrams intravenous or equivalent, intravenous crystalloid for hypotension, 1 to 2 liters, bronchodilators for bronchospasm, and oxygen. Glucagon 1 to 5 milligrams intravenously over 5 minutes may help beta-block patients with refractory hypotension. Methylene blue has been described for refractory shock. The board principle is that adjuncts do not replace epinephrine. Biphasic anaphylaxis is recurrence of symptoms hours after the initial reaction, typically 4 to 8 hours later, but possible up to 72 hours. The board number is biphasic reactions occur in roughly 5 to 20% of cases. The next step after resolution is at minimum 4 to 6 hours of observation, with longer monitoring for severe or delayed onset reactions. Risk factors include severe initial reaction, delayed epinephrine, hypotension, and need for more than 1 epinephrine dose. Observation periods vary by guideline and risk. A reasonable framework is 4 to 6 hours of observation for uncomplicated cases that resolve quickly, longer for severe or refractory cases. All patients require an epinephrine autoinjector prescription, allergy specialist referral, trigger avoidance education, and a return precaution discussion. Angioedema has 2 main pathways: Histamine-mediated angioedema typically presents with urticaria and itching, responds to antihistamines, steroids, and epinephrine, and is associated with allergic triggers. Bradykinin-mediated angioedema typically presents without urticaria or itching, does not respond to antihistamines or epinephrine, and is associated with ACE inhibitor use or hereditary angioedema. C1 esterase inhibitor deficiency is the hereditary form. The board concept is that the absence of urticaria with isolated swelling, especially in a patient on an ACE inhibitor, points to bradykinin angioedema. Treatment differs by mechanism. Histamine-mediated angioedema gets antihistamines, diphenhydramine plus famotidine, steroids, and epinephrine if there is airway concern. Bradykinin-mediated angioedema does not respond to those medications. For hereditary angioedema, the underlying defect is C1 esterase inhibitor deficiency, and specific therapies include C1 esterase inhibitor concentrate, ecallantide, a kallikrein inhibitor, and icatibant, a bradykinin B2 receptor antagonist. Fresh frozen plasma is an alternative when specific therapies are unavailable. ACE inhibitor angioedema may be treated with these agents in severe cases, though evidence is mixed. The classic distractor on the boards is giving steroids and antihistamines for ACE inhibitor angioedema. They do not work because the mediator is bradykinin, not histamine. The most important intervention in any angioedema with airway risk is airway planning. Angioedema is an airway disease. Voice change, tongue swelling, floor of mouth swelling, drooling, stridor, or respiratory distress signals impending obstruction. Call for help early, anesthesia, ENT, and intensive care. Prepare an awake or controlled approach when time allows, ideally fiber optic intubation by the most experienced operator available. Have surgical airway equipment ready at the bedside. Do not wait for complete obstruction. The board concept is that disposition is driven by airway risk, not lip size. A patient with voice change after ACE inhibitor exposure deserves airway evaluation and admission even if the swelling appears mild. The board traps are predictable. Treating anaphylaxis with antihistamines instead of epinephrine, intubating an asthma patient with a high respiratory rate that causes auto-PEEP and arrest, leaving a failing patient on non-invasive ventilation too long, treating ACE inhibitor angioedema like simple allergic reaction while the airway worsens, maximizing oxygen in a COPD patient with chronic hypercapnia, withholding oxygen from a hypoxic COPD patient out of fear of CO2 retention, and underdosing or delaying intramuscular epinephrine in anaphylaxis. Diphenhydramine is the wrong first move in anaphylaxis. Case 1. A 23-year-old with severe asthma is exhausted, barely speaking in two-word phrases with minimal audible wheeze. The end tidal carbon dioxide is rising. This is not improvement. This is impending respiratory failure. Continuous albuterol, ipratropium, intravenous methylprednisolone, magnesium 2 grams intravenous, and prepare for ketamine-facilitated intubation with a large endotracheal tube, low rate, high inspiratory flow, and permissive hypercapnia. The board trap is interpreting the quiet chest as improvement. Case 2. A 60-year-old man taking lisinopril has tongue swelling and a muffled voice. There are no hives or wheeze. This is bradykinin-mediated angioedema. Antihistamines and steroids do not work. The priority is airway planning. Call anesthesia, ENT, and ICU. Prepare for awake fiber optic intubation. Consider C1 esterase inhibitor, ecallantide, or icatibant in severe cases. Discontinue the ACE inhibitor permanently. The board trap is discharging after antihistamines. Question 1. A patient develops hypotension, throat tightness, and wheezing after a bee sting. There are no hives. What is the first medication? The answer is intramuscular epinephrine, 0.3 to 0.5 milligrams in the anterolateral mid-thigh. Skin findings are not required. The board trap is diphenhydramine first while the patient deteriorates. Question 2. An intubated asthma patient becomes hypotensive with high peak airway pressures and poor ventilation. What is the next best step? The answer is to disconnect the ventilator briefly and allow exhalation for 30 to 60 seconds. Auto-PEEP from breath stacking causes hemodynamic collapse. The board trap is increasing the rate, which worsens auto-PEEP. Question 3. A patient on an AC inhibitor has voice change, tongue swelling, and no hives. After airway evaluation and antihistamines, what is the disposition? The answer is admission with airway monitoring, anesthesia or ENT involvement, and ICU consideration. ACE inhibitor angioedema can progress hours into the course. The board trap is discharging the patient because the symptoms appear mild. The final takeaways are these. Severe asthma can present with a quiet chest. Treat aggressively and prepare for a dangerous intubation. Magnesium 2 grams, ketamine, and permissive hypercapnia are the refractory tools. COPD oxygen target is 88 to 92%, but do not withhold oxygen from a hypoxic patient. Non-invasive ventilation is powerful, but failure must be recognized early. Anaphylaxis gets intramuscular epinephrine first. Antihistamines and steroids are adjuncts. Bradykinin angioedema, especially ACE inhibitor angioedema, does not respond to histamine pathway medications. Airway risk, not lip size, determines disposition. Steroids are the wrong answer for the crashing anaphylaxis patient in front of you. References for this lecture include Rosen's Emergency Medicine, 10th edition, Foundations of Emergency Medicine Board Review, the Global Initiative for Asthma, GINA, Guidelines, the Global Initiative for Chronic Obstructive Lung Disease, GOLD Reports, the World Allergy Organization Anaphylaxis Guidance, and the Hereditary Angioedema International Working Group Consensus. Non-invasive ventilation evidence from large trials in COPD and cardiogenic pulmonary edema guides practice. Local institutional protocols govern site-specific medication choices and dosing.